Well, welcome. Today we will be discussing deprescribing and appropriate prescribing. My name is Andrea Levin, and I'm an assistant professor in the College of Pharmacy at Nova Southeastern University. I'm also a board-certified ambulatory care pharmacist, with my practice site being located within the Memorial Healthcare System. Here you can see that I currently do not have any financial disclosures or anything to speak of that will impact this presentation. We have here our learning objectives to describe the purpose of the Beers criteria, to describe some of the problems resulting from polypharmacy. So for example, the prescribing cascade, to identify medications that can be considered for deprescribing, and then also looking at underutilization of medications. So we're looking at deprescribing, but also are there any medications that we might be underutilizing in this patient population? And then potentially some of the adverse effects that could result from inappropriately prescribing certain medications. I'll give you a moment just to look over some of these abbreviations. So now we can see that back in 2015, approximately 9% of the worldwide population was over the age of 65, but that is anticipated to increase by 2030 from 9% to increase to 12%, which will increase even further. The projected increase would be 17% by 2050. So a very large proportion of individuals really the patients that we'll be treating are going to be considered elderly in the upcoming years. So you may be thinking to yourself, well, why does this matter? You know, what are the differences that occur in our patients who are elderly? And really, when we look at that, we look at the pharmacodynamic and pharmacokinetic changes. So as far as in pharmacodynamics, what does the drug do to the body? And it may make, these changes may make someone more sensitive, perhaps, to medications. While looking at the pharmacokinetic, so with pharmacodynamics, what the drug does to the body, and then with pharmacokinetics, what does the body actually do to the drug? And we look at our renal and hepatic clearance. Generally, that is starting to decline in our elderly patients. We also may see an increase in volume of distribution, which could potentially affect the absorption of a medication, which then leads into your last bullet. Now, our renal considerations are something very important when we look at the changes in our elderly patients. We really need to be keeping an eye on their renal function, because with impaired renal function can increase the risk of adverse effects from certain medications that are cleared by the kidneys. Because if you have kidneys that are perhaps not filtering well and they're not working optimally, and you use a certain medication that could be potentially accumulated because it's not being cleared through the kidneys, then that can definitely increase the risk of adverse effects, morbidity, mortality. So very important to keep an eye on GFR, looking at the appropriate staging, also looking at does the patient have macro or microalbuminuria? So do they have an albumin to creatinine ratio that's above 30, but less than 300, which would be microalbuminuria, or do they have an albumin to creatinine ratio that's above 300, which would be macroalbuminuria? Because if you have that, that definitely will give you some insight into a patient's renal function, even if their GFR is at an optimal level. Now, if you have a GFR perhaps in the stage 2 or stage 3 or 4 or 5, in the presence of either micro or macroalbuminuria, that would potentially give you more pause perhaps and more concern as a patient's renal function. So not only looking at the GFR, but also looking at does that patient have micro or macroalbuminuria, because then that could even compound the risk of adverse effects from medications, and it could potentially impact which medications we're choosing. Maybe one medication is better, maybe a different medication is better because it doesn't get cleared through the kidneys. So just being sure that we are being smart about the medications we're using, or maybe we can use a certain medication, but we have to lower the dose when we're starting that medication, or just different things to be mindful of as we're managing our renal patients. Now with polypharmacy, so this is something that I get consults for a lot, looking at patients that are on several medications. You know, are they on a medication to treat the side effect of another medication? You know, looking at that really does lead to the prescribing cascade and the potential for adverse effects. So just being mindful of, you know, trying to streamline the patient's medications. Perhaps they've been on a medication forever, but the recommendations have changed, and now that medication is no longer needed. Sometimes in the outpatient setting, we may say, oh, you know, well, we've been on it, and you know, maybe we should just continue it. But that just, you know, drives that prescribing cascade. And then if they are experiencing a side effect of a medication, needing an additional medication, is there a way to potentially switch, you know, the offending medication, or is there a way to, you know, just be smart with our drug choices to streamline these patients' medications? So some of the medications to target for deprescribing, certain antihypertensives, we have more of our first-line antihypertensive medications. Some of our second-line medications may have more anticholinergic effects. And then potentially orthostatic hypotension. So that could increase the risk of falls and definitely increase the risk of adverse effects in our elderly patients. Certain anti-hyperglycemic medications that can cause hypoglycemia definitely should be targeted for deprescribing. Our NSAIDs could be putting our patients at risk for bleeding. So that is something to be mindful of. Also, it can impact a patient if they have impaired renal function. NSAIDs would also not be a good choice. CNS medications may potentially cause dizziness. They can cause, you know, potentially, you know, as far as respiratory issues with certain medications, your PPIs. You know, I always feel with PPIs, it reminds me of the movie Braveheart, where they're like, what do they say? You can take our land, but you can never take our freedom. I feel like that's the case for proton pump inhibitors. Like, you can take all of my other medications, but please, please, please leave me on my PPI. But we know that long-term PPI use, especially over a year, can increase the risk of bone fractures. Even a shorter duration of PPIs can increase your risk of C. diff, affects your magnesium levels. You know, respiratory, there are just so many negative implications from long-term PPI use. We see a lot that patients perhaps are started on PPIs in the hospital for stress ulcer prophylaxis, discharged on them, and then they take them forever. Also, you may see, you know, that now these are over the counter, so patients are self-medicating with them. Sometimes the perception of over-the-counter medications is that they are much safer than your prescription medications, and patients don't necessarily take them for short term as it's indicated for over-the-counter use. So a lot of issues that arise from your PPIs. Statins, there is less evidence for primary prevention in our patients over the age of 75. So should we be using statins for primary prevention in our 80, 85, 90-year-old patient? That is debatable. And then also bisphosphonates. Are we considering drug holidays for our bisphosphonates? Now the recommendation from the American Association of Clinical Endocrinologists is looking at doing drug holidays, perhaps around the 5-year mark, or maybe a little bit longer if a patient has a very high risk for a fracture, but not keeping the patient on the bisphosphonate forever, because we know that its half-life is, you know, years, and it adheres to the bone matrix. And actually over time, a patient could have non-osteoporosis related fractures since it inhibits osteoclasts. And then also with some of the risks of other adverse effects, for example, osteonecrosis of the jaw, and then also some of the GI effects, especially if a patient is not taking it correctly. Now, when we look at the steps to deprescribing, we always want to make sure that we're organized in our thought process. So looking at, you know, their medication history, doing a proper medication reconciliation, really looking at, is there an indication for a medication, or was that medication perhaps started a while back and it's just been continued? Also looking at an assessment of their medication, so doing a proper medication assessment. How long have they been using the medication? Are they adherent to the medication? do they have multiple prescribers, and one prescriber is prescribing one antihypertensive and another prescriber is prescribing a different antihypertensive that maybe the patient doesn't necessarily need. And then looking at adherence is something that's important, because just because a medication's on a patient's profile doesn't mean they're actually taking it. So let's say their blood pressure is absolutely amazing, and they have like 50 different medications on their profile and they're only taking half of them, then that might be a good medication perhaps. The medications they're not taking are obviously not contributing to their good blood pressure. So being mindful of which medications can be discontinued. And some of those considerations are life expectancy, their preference, how well is it controlling their symptoms, their quality of life, is it curing anything, is it for prevention, again, primary prevention versus secondary prevention, is there a potential for harm? Again, going back to whether or not there's an indication, so benefit versus risk. Is there a risk of ABRs? What are the withdrawal concerns? Are they, again, treating an adverse effect of another medication with this medication? And then also, again, looking at adherence, of course, being so important. And developing a plan for the medication discontinuation, looking at what medication is the highest burden. And it could be cost related. It could be, is this medication twice daily or 3 times a day versus another medication that's once daily? But maybe looking at those highest burden medications and discontinuing those first, but not forgetting to monitor for the effects of discontinuation. Should we be tapering a medication, or should we be doing a hard stop to this medication? Are there potentials for withdrawal or return of symptoms? And then just making sure that we're communicating with all of the healthcare providers, because some EMRs are linked, some are not. So it's important that we make sure that all prescribers are aware, and all of the healthcare providers are aware of a patient's current medications. And a lot of that does fall on the patient and ensuring that they have a most updated list, but just ensuring that we're doing all that we can to know what the patient is actually taking. So now that we've discussed some of the steps and the process that we might be going through when we are looking at deprescribing, we're going to go through some of the algorithms here. And I really like the deprescribing.org. They have some really, really great algorithms. We're going to go through some of their available algorithms, but I would encourage you to take a look. It's developed by a pharmacist and a physician. It's a Canadian resource, and it's a great, it gives you talking points, the whole thing. So we're going to go over several of these, especially as it relates to our elderly patients. So looking at our PPIs. So it's very important when we're thinking about PPI use, should the patient be on it? Did they have an ulcer where they should be on perhaps limited, duration of treatment? Did they have an endoscopy that came back and perhaps they, needed treatment post-endoscopy, or looking at stress ulcer prophylaxis? For the majority of these patients, or even looking at mild to moderate GERD or esophagitis, potentially recommending deprescribing. However, when we look at our patients with Barrett's, for example, or history of bleeding, especially so GI bleeding with NSAID use, bleeding ulcer, those patients should definitely be on their PPI. But for the vast majority of patients, we could recommend deprescribing. So then the question comes into play, well, should we use a lower dose? Should we stop and use PRN or as needed? Should we do a taper? So again, there are so many different considerations, and this guideline is great because it does discuss that. So as far as decreasing to a lower dose, that if we were to do that, there's no increased risk in return of symptoms compared to consuming a higher dose. And then just stopping and using on demand, perhaps that could be an option as well. But also potentially looking at doing a taper of this medication, but we would look at doing deprescribing. That would be a really good approach, especially given some of the risks of long-term PPI use. Could we potentially use over-the-counter H2 receptor antagonists? So, for example, famotidine, with Zantac having some concerns and being pulled from the market currently. There are other H2 receptor antagonists that we could potentially use in lieu of a PPI. So again, this goes through which patients should continue on their PPI, which one should be recommended for deprescribing, what are the options for deprescribing, and just going through all of the different considerations. And then it also gives you an idea, someone's on a standard dose, maybe even going to a lower dose. And also, how do you engage patients and caregivers? What are some of the side effects to discuss? As we had talked about before, the risk of fractures, C. diff, diarrhea, potential respiratory pneumonia, B12 deficiency, and effects on magnesium. So there are just so many different options there, and also looking at tapering. No evidence that tapering is a better approach, but sometimes even psychologically it might be a good option for some patients. Again, all good choices here. So this is a great guideline. I would definitely encourage you all to, again, download the app. There's always an app. There's an app for that. So there's an app for this as well. But now what about underutilization? So the omission of drug therapy. So for example, reasons for underutilization might be an increased risk for adverse effects. Maybe we're concerned about that. Maybe the patient's on so many medications already that we just don't want to overburden the patient. Perhaps their life expectancy or comorbid conditions. And we see that a lot. I do a lot of management of diabetes, and should we have them at a really low blood sugar, or is that going to potentially increase their risk of hypoglycemia? So looking at the A1C and really making that determination. Or maybe just omission. The patient, maybe they don't follow up as regularly as we would like, for well visits and, a yearly physical, or maybe even coming back every 3 to 6 months, depending on their comorbid conditions. And they only come in when they're not feeling well. And you prioritize that as their, reason for their visit. But perhaps that omission just could be from that or so many other factors. And then also, again, we have very limited evidence in our elderly patient population. So, we run into that problem sometimes with our pediatric patients and our elderly patients as far as the amount of evidence that we have. So going through the Beers criteria, so we have the Beers criteria and the potential for inappropriate medications. Please know that this guideline, these recommendations, it does not mean that you must adhere to this. There are always going to be considerations that come up where perhaps a medication that's on the Beers list, which is, maybe it's a medication that's not recommended, maybe in a certain patient would be a good medication to use. So there's always going to be benefits and risk scenarios that we have to be mindful of. But we are going to discuss the 2019 update. The last update prior to that was 2015. And then we are also going to be looking at our screening tool for older prescriptions, for older people's prescriptions, so the stop and the start criteria as well. So when we see the medications that are on the Beers criteria, these are generally medications that can increase the risk of confusion, potentially falls, mortality, and again, just being mindful that if we avoid these medications, perhaps we can decrease the risk of adverse drug events. So some specific updates looking at aspirin. There have been numerous studies that in primary prevention that we should not be using aspirin because it can increase the risk of bleeding. Also, as far as Bactrim in renal function, I don't think that that's really a very new recommendation. But perhaps having extra consideration in an individual who's on ACE or an ARB with reduced renal function and thinking about adding Bactrim to that, maybe that could be a potential concern. But again, nothing necessarily groundbreaking new, just to remind you of the concerns with Bactrim in individuals with impaired renal function. And also, when we see some of the potential bleeding risks. We always had dabigatran on the Beers list, but it also now includes rivaroxaban, as well as potentially increasing the risk of bleeding. for individuals for treating VTE or AFib. So just realizing that now rivaroxaban has been added to that list. Tramadol also being added to the list. It has its own side effects, but it now also has been found to increase the risk for hyponatremia. Vasodilators were removed from the list, not that they're safe to use, but that the side effects, it's a very common side effect. It's not specific to our elderly patients. And as well as your chemotherapeutic medications being removed. Again, not that they're not, potentially increasing the risk of adverse outcomes, but they were removed because the side effects, are pretty similar across the board. And again, these are necessary medications, so those were removed from the Beers criteria. And then for H2 blockers, they were removed from the list because we know that they are a much better option for our patients that are on PPIs. Sometimes we can switch them to PRN or as needed H2 blockers. So those are removed from the list. Glimepiride was added. It used to be that glyburide was the only medication that was on the Beers list to avoid as far as sulfonylureas go, but now glimepiride was added to that list. So really glipizide is our preferred sulfonylurea if we're going that route. Not that it is void of hypoglycemia risk, but that it is a safer option since it does not go, it doesn't accumulate renally. Our SNRIs, potentially increasing the risk for falls or fractures, so avoiding those medications. And then looking at some of our patients with Parkinson's and which medications are preferred, some of our antipsychotics, looking at non-VHP calcium channel blockers being avoided in HFrEF patients, again, nothing new there. And then looking at which medication should be used with caution in our patients with heart failure, NSAIDs, COX-2 inhibitors, TZDs. Again, nothing new, just certain medications that were being added to this list. So drug-drug interactions, again, a lot with Bactrim. Also potentially CNS agents increasing the risk for falls. Kidney function, looking at Cipro and Bactrim, increasing the risk of CNS effects. With Cipro, you especially see those risks of tendon rupture. Again, a lot with Bactrim and hyperkalemia in patients with worsening renal function. So just being mindful of some of the additions. Again, nothing that's necessarily groundbreaking, but just additions to this list to catch up with all of the studies that have been done. So utilizing the Beers criteria, we see here that for our therapeutic category, so with our anticholinergic medications, again, increase the risk of some of those anticholinergic side effects, like for example, diphenhydramine or Benadryl. Increases the risk of confusion, dry mouth, constipation, increases the risk for falls. Obviously, if a patient is having an allergic reaction, diphenhydramine would be appropriate, but sometimes patients use it for sleep, and that is not recommended in our elderly patients. As far as nitrofurantoin, looking at renal function is also something that is important. Our alpha blockers increase the risk of orthostatic hypotension, like doxazocin. Generally, we don't use these medications for the treatment of hypertension. Perhaps if a patient has hypertension as well as BPH, you may see these medications being used, but even still with that, for BPH, we do have alpha blockers that are more specific for the prostate. That would probably be a little bit of a safer option. Our centrally acting alpha-2 agonists, such as clonidine or methyldopa, we do avoid these as first line. They can cause bradycardia, orthostatic hypotension. Digoxin has its concerns as far as just not using it first line in our AFib patients and heart failure. There's a lot of conflicting evidence as whether or not there's benefit. If we are going to use it, really making sure that we're using a lower dose. And then for our renal patients, just making sure again that we keep that dose low. For our antidepressants, there are some that are highly anticholinergic and that leads to sedation, orthostasis. So just being mindful of avoiding those antidepressants if possible. Antipsychotics, increasing the risk of stroke and cognitive decline. We really want to make sure that we're avoiding those medications in behavioral complications of dementia. unless their options have failed or they have concomitant schizophrenia. But we want to make sure that we're not overusing antipsychotics. Our benzos, of course, there's increased risk of cognitive impairment. For our barbiturates, the addiction potential, overdose, and then our Z drugs or sleep aids can definitely increase the risk of delirium, falls, fractures, a lot of those side effects. So now we discussed some of the updates, but with antipsychotics, how do we approach this? So again, when we're looking at the patient, do they have BPSD, so behavioral and psychological symptoms of dementia? Because in those patients especially, we should recommend deprescribing. Or is it potentially that they're using it for insomnia? Unfortunately, sometimes we still see that. I think it's gotten better. But I have seen on very rare occurrence a patient on quetiapine for insomnia. So any patients that are using antipsychotics for sleep or potentially for that BPSD, and then we should target those patients for deprescribing. But it's very important that with our antipsychotics that we do a taper and stop, as opposed to discontinuation like we saw with our PPIs. Even though you could do a taper with a PPI, you don't necessarily have to, you could stop it, but with our antipsychotics, we really should look at doing a taper. So either doing a 25 to 50% dose reduction every 1 to 2 weeks, and then really monitoring for those side effects of tapering. So are there benefits? Is the patient more alert now? Is their gait, has their gait improved? Have they had a reduction in falls? And then, but then also have they had some increase in psychosis or aggression? So again, just being mindful. So perhaps doing that, a slow taper, doing 25% dose reduction every 1 to 2 weeks, maybe even expanding that out to 25% every 2 weeks, just to ensure that we're trying to minimize those risks for withdrawal. And then looking at some of the non-drug approaches, music therapy, behavioral therapy. And then if a patient does need an antipsychotic, and we could potentially put them on the lowest effective dose, and maybe after 3 months of treatment, then trying to taper and eventually stop that medication as well. But again, looking at the patients that are not good candidates to stop an antipsychotic, so such as your patients with schizophrenia, there's a whole list that you can see here. So just being mindful of some of the benefits of deprescribing. What are the recommendations? Should you taper? Should you just discontinue? How long should the taper be? So all that information is available to you. If a patient is using it for insomnia, it gives you, recommendations as far as sleep hygiene, and different things to help a patient sleep without the use of an antipsychotic. And then, of course, it gives you doses and how to engage patients, looking at the rationale, looking at the benefit of tapering, really recommending tapering, and then also sleep management, and gives you a lot of great insight. And then as far as your benzodiazepines and your Z drugs, really looking at the reasoning, why are they taking it? Whether or not it should be continued. So for example, for alcohol withdrawal, we will use our benzodiazepines, but if a patient is using it for insomnia, perhaps, they've been taking it for a while, it might be a good idea to deprescribe. But very important though, you must make sure that you are tapering these medications. Like with your antipsychotics, you want to make sure you taper. With your benzos, you also want to taper as well. Because if you abruptly discontinue, it can increase the risk for seizures. It has a whole slew of side effects. So with your benzos, just make sure that you are tapering those, doing a very slow taper, 25% or maybe even 12.5% reduction every 2 weeks or so. So again, there's some great resources here looking at how long has the patient been on a benzo, looking at other options that are available. When should the medication be tapered? When should it not? What are some of the non-pharmacologic options if a patient is able to successfully be discontinued off of these medications? So, and then what are the improvements? So alertness, cognition, reduction in daytime sedation. So just being mindful of some of the benefits that arise. And again, they give you those talking points, a lot of emphasis on how to taper, some of the behavioral managements that can be an adjunct to pharmacologic therapy if you're able to lower the dose, but maybe not just discontinue it completely. You can pair that with behavioral, or even if you are successfully able to deprescribe, looking at that behavioral management. Your cholinesterase inhibitors and your memantine. So for patients with Alzheimer's, Alzheimer's disease, sometimes it's used in patients with just dementia, Parkinson's, Lewy body dementia. Really looking at the benefit of these medications. Have they been taking them for over 12 months? And have there been any improvements, or have they really had no improvements? Because if they haven't had any improvements, we want to look at potentially deprescribing these medications, because generally you should see some benefit in a few months on these medications. So if you haven't seen that benefit, then potentially looking at doing a taper and then eventually stopping the medication. And then as far as what to look out for, what to monitor for during tapering and discontinuation as the time frame increases, and who is suitable, of course, for deprescribing, and how to engage family members and caregivers in ensuring that this is the best choice for the patient. So a little bit more on Beer's criteria. So as far as your estrogen plus or minus progestin, really ensuring that you're using the lowest effective dose for the shortest duration as possible. If you do need to use it, being mindful that if a patient is having vaginal symptoms, they should be using vaginal formulations as opposed to systemic formulations because of the risk of cancer, and also for VTE. We see those risks in oral and also transdermal formulations. So just to be mindful of what type of symptoms. Are they vasomotor symptoms, or are they vaginal? If it's vaginal symptoms, again, using vaginal formulations. Vasomotor gets a little tricky because vaginal formulations won't help your vasomotor symptoms, but again, using systemic therapy will increase your risk potentially for breast cancer, potentially for stroke, so just being mindful of those risks. As far as testosterone, again, just being very careful. There are cardiac concerns, also patients' history of prostate cancer. For your insulin sliding scale, it can increase the risk of hypoglycemia without improvement in hyperglycemia. It's also a very reactive method of diabetes management as opposed to being proactive. So you do want to definitely use caution and really avoid sliding scales, really in any of your patients, not necessarily just Beer's criteria, because again, you want to make sure that the patient is, being proactive in their blood glucose therapy. With sulfonylureas, again, the risk of hypoglycemia. So we do want to make sure that we're avoiding all first-generation sulfonylureas, such as chlorpropamide, but also avoiding glyburide and glimepiride, which was recently added. TZDs, again, avoiding heart failure. PPI is your C. diff risk. Bone fractures. H2 blockers, again, now are an acceptable option, especially as an alternative to PPI use. And then looking at antihyperglycemics as far as deprescribing, as I had discussed on the previous slide, with glipizide, glyburide, glimepiride, with glimepiride and glyburide being on Beer's list. Looking at what are the other medications that the patient is on. Are there other therapies perhaps that don't confer that risk of hypoglycemia? Or perhaps, maybe they're at goal and they're on a low dose sulfonylurea, and maybe we can stop that. So again, looking at, can we reduce the dose, or can we stop it? Can we switch it to something that does not have that hypoglycemia risk? And then looking at the renal implications of it. If we do have to use a sulfonylurea, are we using glipizide as opposed to glyburide or glimepiride? And then here again, talking points. Some of the risks of hypoglycemia to explain it to a patient or a caregiver. For your NSAIDs, again, realizing the risk of GI bleeding, ulcer, so just being mindful of those things. Muscle relaxants are generally poorly tolerated, can have increased risk of fractures because of falls. And then some other questions to consider, again, looking at, is there an indication for this drug? Is it effective? Is the dose correct? Perhaps, patient may be on 3 medications to treat one condition, but all the doses of those 3 medications are very low. So maybe we can consolidate their medications. What about the directions? Is it also practical for a patient? And then looking at the drug-to-drug interactions, the drug-disease state interactions, are there duplications of therapy, the duration of therapy, maybe they're on a medication for longer than they need. For example, dual antiplatelet therapy. So, and then also is there looking at cost. Now we're going to move on to our case. So we have our patient, we have Christopher Tor, or Chris Tor, is a 68-year-old Hispanic male, presents to your clinic to establish care. His chief complaint is constipation and a concern with his at-home BP of a blood pressure averaging 162/92 and a heart rate of 68. He had an MI about 4 years ago, and he also has asthma, no known drug allergies. We have some labs here, and we have his medication. So currently he's on clonidine 0.1 milligrams BID, glipizide 5 milligrams PO before breakfast. We have Advil PM, Benadryl as needed, albuterol as needed, and we have an aspirin. So how would you approach this patient? So I'll give you a moment just to think about that. So I'm sure that you're thinking about, well, his chief complaint. So he's got constipation, right? And a concern with his blood pressure. So which medications can be leading to his constipation? So for example, looking at clonidine, looking at his Advil PM, his Benadryl PM, those are all concerns. He had a heart attack, so he's on Advil. That's also potentially an issue. His renal function's not doing that great. So, discontinuing the Advil PM, the Benadryl PRN, and also clonidine. Clonidine increases your anticholinergic side effects. So should we taper? So, and is clonidine even a first-line option? So looking at this patient, his blood pressure is so high, he really should be on at least 2 medications for blood pressure lowering. His renal function is not that good, so we can consider an ACE or an ARB. Also looking at potentially a beta blocker that's a selective beta 1 because he has asthma and he had an MI. But again, tapering the clonidine, since that can be increasing his risk for constipation, discontinuing the Advil, discontinuing the Benadryl, initiating perhaps an ACE or an ARB because of his renal function, and then also a beta blocker because of his history of a heart attack. He's not on a beta blocker, but ensuring that you're not going to cause an asthma exacerbation. It would be a benefit to do a beta 1 selective, such as metoprolol, would be an option. You may be thinking to yourself, well, the aspirin, is that a good option? But remember, though, he did have a past medical history of an MI. So even though aspirin is not recommended for primary prevention, it would be recommended for secondary prevention. So we would keep that, potentially reduce so taper and discontinue the clonidine, initiate an ACE or an ARB and beta 1 selective beta blocker. Looking at the glipizide, so the patient, if he has he has diabetes, but his sugar is 90, so he's on a really low dose of glipizide. Maybe he doesn't need to be on that. So potentially discontinuing the glipizide, and then considering other medications. Now, unfortunately, we can't do metformin for this patient because his GFR is less than 45, so we wouldn't want to start metformin. But there are other options if he still does need some blood glucose lowering, or maybe he doesn't need any additional lowering since his fasting is 90. That's pretty good. And then, of course, keeping the albuterol on board. So yeah, there are a lot of different considerations to be made. So of course, the primary is the constipation, which is definitely being caused by the Advil PM, the Benadryl, and then also clonidine, and then his blood pressure. So getting him on 2 agents that also are helpful for his kidneys and also potentially for his history of an MI. For your resources, don't forget about primary literature guidelines. There are a lot of drug information resources, and just staying current with all the new things coming out. So in summary, just some considerations for your patients that I'll leave you with. We talked a lot about many of these things, but as far as cost is often a big concern for our patients. As far as the different coupons and things, like manufacturer coupons are not, don't work for your Medicare patients, so that could negatively impact your elderly patients if they are on Medicare. The manufacturer coupons won't work for them. So are there other patient assistance programs that are available? And then looking at different adherence tools, assessing their health literacy, numeracy, and also understanding our cultural differences, because there might be some different ideas that, with certain medications based on the patient's culture. So just being sensitive to that and aware of those differences. So thank you so much. I will ask that you scan the following QR code, and if you can complete the survey, we greatly appreciate it. And thank you so much for your time and attention.